my class. Today I discuss about the topic of delirium. So what is delirium? Delirium is normally a brain disorder. It is disturbed 3C, that is cognition, concentration, consciousness, and last one is cognition. So it is not a disease, it is a group of syndrome. Next we will see the history of delirium. The word delirium exists in medical literature since the last 2015 years, and almost 15 years ago George E. England and John Romano postulated that delirium was irreversible cerebral insufficiency, and in 1918 the third edition of Diagnostic and Statistical Manual of Mental Disorder DSM-3 was the first attempt to standardize delirium is a nomenclature. Next we will see the epidemiology of delirium. The highest rate of delirium is found in post-cardiotropy patients. 20% of patients suffering with burn disorder and 40 to 30% of patients with AIDS. Next, what are the risk factors of delirium? So delirium risk factor deals with the vision impairment, hypertension, medical illness, COPD, post-operative, cognitive impairment including alcohol abuse, functional limitations, abnormal bilirubin level, electrolyte level, all the things. Next, the causes of delirium including vascular involving brain damage or brain trauma, infection, neoplastic, intoxication, rheumatic, vitamin deficiency, endocrine and metabolic disorders. Next, see the clinical features of delirium. The clinical features of delirium is divided into 7 classifications: impairment of consciousness, impairment of attention, disturbance of perception, disturbance of cognition, psychomotor disturbance, disturbance of sleep, and emotional disturbance. Next, diagnostic criteria of a delirium. So the diagnostic criteria of delirium, first one is the mental status examination, but the mental status examination is not defined delirium. It can be only defined the person is normal or abnormal, not specific for distinguishing delirium from dementia, may be used to ask to change from baseline. Next one, see the laboratory investigation to find out the delirium, including standard studies like blood chemistries, complete blood counting, thyroid function test, serological test including syphilis, human immunodeficiency, that is HIV, and urine analysis. Next is the EEG, electroencephalogram, chest radiology or radiography can be find out the delirium. The additional tests including blood, urine, and cerebrospinal fluids study, otherwise folic acid concentration studies, computer tomography or magnetic resonance imaging, brain scans of arachnoid hemorrhage, subdural hematomas. Next we will see the treatment of delirium. The treatment of delirium including pharmacological treatment and non-pharmacological treatment. First one is the pharmacological treatments. The pharmacological treatment can be treat with the patient agitation and psychosis. For the reduction of psychosis and agitation, we will use for antipsychotic medications. For example, is apsychotic, antipsychotic, and typical antipsychotic. So typical antipsychotic including haloperidol, benzodiazepine. First see the haloperidol. Try to use only for severe agitations, lowest anticholinergic activity of all major neurologic hypotension. So the dosage of the haloperidol is 0.5 to 1 milligram initial dose. It can be used only for 4 mg per day. So the repeat dosage for 2 to 4 hours. Next one is the risperidone, olanzapine, and quetiapine. It can be given the dosage of risperidone is 0.25 mg BD and olanzapine is 2.5 mg per D. Last one is the quetiapine. Quetiapine given for the dosage is 12 to 5 mg per day. Next we will see the typical antipsychotics, benzodiazepines. So benzodiazepines can be maybe increase the agitations, best reserved for delirium 2% or relatively contraindicated delirium from hepatic encephalopathy. So next one is the ECT. ECT is a non-medical treatment. It can be given when the medical pharmacological management can be failed. That time we can approach for ECT treatment. It staffing for the delirious patient also assisting. Reduction, otherwise improve the education of the family and the patients also. Next is counseling, otherwise family companions. Counseling and family companion include the family members as well as the patients also. The cooperative family members may stay with the patient to provide orientations and the reassurance to the patients. Same as the counseling and the rehabilitation also very much important to the recover of the delirious patients. Patient and family educations including the delirious episode, the families can be educated as to appropriate always to supportive to the patients as well as to what information is important to convey to the medical team. The knowledge about the delirium risk, increased mortality and the functional rate. Next. So these are the delirium, about our delirium topics. We also need the what is the causes of the delirium, how it will be managed, what are the medication management, that's all.